coming in to join us this afternoon. So, hello everyone. My name is Montserrat Llamas. I am the lead community health worker here at Mishwa. I am going to introduce our speaker today, which is Carl Rush, and he is a principal consultant at Community Resources LLC in San Antonio, Texas. Carl has specialized in policy and workforce development for CHWs since 1996. He has advised CHW policy initiatives in more than 20 individual states and groups of states for ASTO and other national organizations. He was a lead author on HRSA's 2007 CHW National Workforce Study and co-led on the CHW Core Consensus Project from 2013 to 2016. Carl convened the National Conference on Financial Sustainability for CHWs in 2001 and has recently completed 2 national studies with the CDC on CHW certification and workforce development. He is also a member of the National Association of Community Health Workers Policy Committee. So without further ado, I'll give you the floor. Mr. Rush, thank you for being with us today.
Thank you very much, Montse and Tressa, for the invitation to be here today. This is a great opportunity. We had a session on this topic on Tuesday for community health workers, and we had about 150 people on the webinar, which was just tremendous. This is the largest one that we've ever had. So just a quick rundown on why we're doing this, what it's about. As you know, there is a lot of talk about Medicaid financing for community health worker services nationally, and apparently a window of opportunity there in Michigan to expand the coverage of of CHW services. And in the consideration of any policy like this, it is the position of NACHW and other organizations like Michwa that community health workers need to be at the table. And that said, as you can imagine, when we get into the details of what Medicaid is about, it gets pretty technical, pretty complicated. So we want community health workers who are involved in this process to be familiar with what we call the back end of Medicaid. And I'll come back to this in a second, but most community health workers know a lot about the front end, about the services that Medicaid provides, how to enroll for Medicaid and how to access services and so on. But the back end is a mystery to a lot of people. And so we felt it was important to give some background on that topic. So what we would like you to do, if you have not already done so, is to enter in the chat your name and an organization and a yes or no as to whether you are a member of the National Association of CHWs. Most of you would qualify as ally members, but we would appreciate knowing whether you are in fact a member. And the group is a little bit too large for everybody to introduce yourselves verbally. So if you would please just do that, and I will move on. What we relevant to the point that I just made about CHWs knowing a fair amount about Medicaid, we polled the CHW participants in Tuesday's webinar, and it turns out that a lot of them have experience, both direct experience with Medicaid, receiving benefits under Medicaid, and with working with individuals or families on Medicaid topics. And so this supports the general notion that people know what Medicaid does, but not necessarily how Medicaid does it, how Medicaid decides what to pay for, how services are paid for, and that sort of thing. And so there are, I think everybody's familiar with some of the opportunities that Medicaid presents. When it was originally created, it was a great opportunity for relief to people who cannot otherwise afford healthcare. And it is now across the country, a growing number of states have adopted the expanded Medicaid available under the Affordable Care Act. And there are a number of reforms that are being instituted to improve the way Medicaid provides for healthcare. So what at the same time, I think everybody's familiar with the fact that most providers feel that Medicaid payment rates are not high enough. That is no secret, certainly. It's true across the board. But there are other challenges with the availability of providers who will accept Medicaid, and that the billing process can be burdensome for the providers. But above all, it is complicated to understand. So we're trying to get at this a little bit. So what I would like to do, Montse, if we could pull up that poll real quickly, we have a one question poll for you about how confident you feel in discussing Medicaid policies. Can we pull that up real quick? Okay. So if you could please respond to that real quickly, and we will proceed once we've got a reading on that. We've got a few more people out there who have not responded. But okay, let's go ahead and close that, Monse. So I guess the point here is there's not a whole lot of you who are totally confident, shall we say, in the 4 or 5 in your level of confidence on Medicaid. So we're going to try and cover some of the there we go. Okay. So what we're going to try and cover today, and we are going to do some small group work to get you all more involved in the discussion. But what we're going to discuss today is very briefly the purpose and history of Medicaid, how it came to be. It's a little more complicated than many people realize. What the basic eligibility categories are, and this is significant because it affects what people need to be able to show to qualify, and the fact that states will vary. There's some services that are required, the states are required to offer mandatory benefits under Medicaid, and some that the states have chosen to offer optionally. We'll go into some detail in terms of the ways that Medicaid pays for services, and this is where things really begin to get more complicated because there are a lot of options here, and there are some ways that are more appealing, shall we say, than others. And then specifically for community health workers, what are some of the challenges in getting Medicaid to pay for what they do, and what are some of the opportunities that are presented by the changes that are happening right now as we speak? And this is an important consideration because we do have a window of opportunity. Perhaps there may be some things politically that will be more difficult in a couple of years, and are there opportunities to capitalize on the favorable climate in the current administration? And then very importantly, this is one of the reasons why it's so important that community health workers and you as employers and allies of CHWs be familiar with these policies, is because if the state begins to take on a more ambitious program of payment for CHW work under Medicaid, there are some key aspects to that payment policies and the choices the state can make about payment policy that will profoundly affect the work of CHWs. So it's important to be at the table and mindful of those opportunities. So basically, and most of you are quite familiar with this, but Medicaid was created as medical assistance as it's often called that at the state level, a medical assistance program. It is an entitlement program, meaning that if you meet the eligibility criteria, you can enroll to receive benefits. And but the program was conceived as a way of paying for health care for low-income individuals. That was the total concept behind it. One of the things that is unique, as distinct from, say, Medicare, which is a totally federal program, that Medicaid is a federal-state partnership, and so the the federal government pays a percentage of the cost of the program, which varies depending on the average income levels in a particular state, and that can vary anywhere from 50% for very wealthy states. The federal government doesn't feel a need to pay for that much of the cost, up to like 85% for the poorest states. And Michigan is somewhere in the middle at around, I believe, 65%. But that means that it's still a big budget item for the state, but a large portion of it is covered by the federal government. So the basic, what we consider the founding, formative legislation of Medicaid was a series of amendments to the Social Security Act in 1965, which was part of President Johnson's Great Society or War on Poverty programs. And it was integral to relieving some of the most burdensome aspects of being poor in America. So it was quite a breakthrough. It was adopted gradually by the states. Arizona held out until 1983 before they joined the program, and they, in fact, chose not to call it anything like Medicaid. But one of the things that many people are not aware of is that the eligibility for this program has expanded gradually. It's not, it wasn't born looking the way it does today with a bunch of different eligibility categories. It was originally much simpler. And the Affordable Care Act, of course, created a major shift with the provision for expansion, which even some of the holdout states are beginning to see the wisdom of adopting Medicaid expansion, which was originally paid for in the beginning years with 100% federal support, and that has since declined to 90%. But that's still better. It's still a better deal for the state than the original Medicaid coverage, and it was meant to be an incentive for states to begin to cover people at slightly higher levels of income. In many states, the income levels, the limits on income for Medicaid eligibility were quite low, and the expansion is an incentive to begin to cover people at slightly higher incomes. There were a number of emergency measures, excuse me, I apologize for the cough. A number of emergency measures adopted during the pandemic, and one of the issues we're looking at right now is how we create a kind of an off-ramp or a glide path for people who remained eligible for Medicaid during the pandemic and find themselves potentially losing their eligibility, and what the states can do for it. But the rules were eased quite a bit because of the number of people who had not only medical needs, but were either laid off from their job or were unable to work in terms of being unable to find childcare and things like that. So the pandemic was very significant. for the current state of Medicaid. Now, eligibility, as I said, for Medicaid is not has not always been what it was. Many people are not aware that the federal government, it wasn't called Medicaid, of course, back then, but back in 1950, the federal government began paying for nursing home stays, and this was a breakthrough because this was a hardship as people were living longer. And you're all aware, of course, that our life expectancy during the 20th century increased quite a bit, and most people couldn't expect to live beyond, say, age 50 at the beginning of the 20th century. So nursing home payments became very burdensome to people. So this was introduced in 1950. The basic amendments, as I described in the Medicaid Act and other legislation, added income-based medical benefits, meaning paying for actual hospitalization and doctor visits, so on. And the first category that was made eligible is people who were receiving what we used to call welfare, now called TANF, or the first recipients of medical assistance under Medicaid were people who received cash assistance. And that has gradually changed so that a large percentage of people on Medicaid now are actually working. And that's one of the things that many states don't quite appreciate when they add things like work requirements to Medicaid eligibility. That most of these folks are already working. What are we doing? What are we trying to do here? The well child care benefits. Oops, come on up. You can do it. Well child benefits, or EPSTT, were added in 1967. And that has been a breakthrough in terms of being able to keep young children healthy. But pregnant women and children were not added until 1989. And many people don't realize that that's, as a category, that was as late in coming as it was. The older kids were added the next year, which has become also very significant because of the changes implemented through the ACA. CHIP coverage came shortly after that, which was to enable families with slightly higher incomes to have coverage for their kids. And I think you can see a pattern here that the priorities of the federal government tended to be towards the health and well-being of children, that the federal government is willing to pay more money for the health and well-being of children who obviously can't obtain medical care on their own than they are for adults. And then, of course, the Medicaid expansion, which added a substantial number of adults without children who had previously only been able to get coverage if they were disabled. Well, one of the important concepts, which is probably not news to most of you, but that the income limits for eligibility vary by eligibility category. In other words, a family may have, depending on their income, they may have some family members who are eligible and some who are not, just because of where they fall in the income scale. By the way, if you all have questions or comments, I hope you are putting them in the chat. We will hopefully be able to get to those. And Montse, if there are any significant questions that you see in the chat, please interrupt me, and we will get to them. Okay, so those are some of the basics. Now I'm going to ask to put you to work. We're going to put you in small groups in chat rooms for about 10 minutes. And when we go to the chat, we would like you to be prepared, have some member of your small group be prepared to enter. Any of you, I guess, can enter in the chat if you want. Significant observations that came up in your small group on these two questions. The first is, what is one thing you know about Medicaid that you think others in this workshop might not know? It is quite possible some things you take for granted that others here are not aware of, and we really want you to share your experience, your wisdom on this. And the second is, what's one thing you've learned so far that surprises you, that you weren't expecting to be the case, in a good way or a bad way, doesn't matter. But so if we could go to chats for about 10 minutes, we will call you back and ask you to report on this in the chat. So are there any urgent questions, Montse, that we maybe should address before we go to the groups?
I do not see any, Carl.
Okay, great. Well, let's go ahead and put you into the chat rooms, and let's see what you think about these questions that others might not know. And one thing you've learned so far that surprised you. While you're doing that, I want to respond to a question in the chat from Tressa just before we went to the small groups about individuals with disabilities. Is there an income qualification for them too? Yes, there is. And we will get into some details about what sort of the minimum federal standard is for each of the eligibility categories in a second. A comment about the public health emergency for the pandemic. Once that is over, the states have a year to re-enroll or redetermine their Medicaid population. So each state has to figure out how they want to do that, and that's pretty important because it could be a sudden blow to people to lose their eligibility. Thank you for that. Okay. So yeah, please continue to post those observations. And we will be, Monse, I hope we can save the chat at the end of the webinar, so we have all of these notes captured. Would appreciate it.
They will be seen.
Yep. Okay, so while you're doing that, I'm going to while you're continuing to enter your comments from the small groups, I'm going to go ahead here. Pardon me. There are a few special cases of eligibility that are a little different from the others. I'm going to go through those quickly. Many of you are familiar, of course, with people who are eligible for both Medicare and Medicaid, and these may be elderly or disabled. And there are rules about who pays first for people who are dually eligible. But that is clearly a population where a fair amount of assistance is needed for those recipients. There are some emergency services that can be provided to undocumented folks, and there are specific rules for those as well. People who are currently incarcerated, may receive certain inpatient hospital or nursing home care services from Medicaid. And foster children, this is an interesting, the Affordable Care Act, as you know, made it possible for children to remain on their parents' insurance coverage up to age 26, but it also allows Medicaid coverage for foster children up until they reach age 26. And that is, of course, part of a broad general concern for the aging out of the foster care population. Huh. So here's where we get down to this. It is interesting that you can see a pattern here. Now, these are, without going into the specifics of what Michigan's eligibility levels are, the income limits for eligibility. The federal government now specifies that children in general and pregnant women are covered at a higher percentage of federal poverty level than other eligibility groups. But there was a specific question about, oh my goodness, what happened here? Okay, wait a minute. There. I'm seeing something different on my screen all of a sudden. Anyway, we're okay. There was a question about income levels for disabled recipients. And in fact, that's interesting. Montse, I'm seeing your screen. Are you trying to share your screen?
Yeah,
Okay.
sorry, it wasn't pulled up on the presentation.
I see. Okay, great. Okay, so that the disabled in general are only covered up to a fairly low income level, and
Can
the
you share
highest.
your screen, Carol? Because we can't see your screen.
Oh, did you lose it? Okay. Sorry about that. Okay, we back?
Yes.
Okay. That the highest income level of any of the states that supports benefits for disabled individuals is only 100% of poverty. And so it's this is an interesting phenomenon. Sorry, I keep losing this. There we go, losing control. That for example, for nursing home care, there are limits to not just income, but the assets that an individual or family has. And that has been a contentious issue for people needing long-term care, that there was a matter of having to spend down the family's assets before Medicaid would kick in. And that can be a very sensitive topic. There was an effort over many years to get people to pay for long-term care insurance, but it never really caught on. So it is still true that most of the nursing home care in this country is paid for by Medicaid, but people have to expend a lot of their assets on care before they become eligible for care under Medicaid. It is a very interesting phenomenon. But the other point I wanted to make is you can see that the states vary. There are only a few categories where the lowest limit states are the same as the federal limit, like pregnant women. There are some states that are at 138% income limit. But there are, for all of these categories, there are states that are providing coverage at much higher levels of income than the federal government requires them to cover. These are generally wealthier states, but they will provide Medicaid coverage for kids, for example, at up to 324% of poverty, or 380% in the case of pregnant women. So it's clear that there is a priority, not just in the federal government, but in most of the states, for providing coverage to these categories of recipients. That could be a whole separate webinar about how eligibility is determined and why they prioritize it in this way. But the picture has, of course, changed since the Affordable Care Act with expansion and the availability of the marketplace insurance coverage. So another huge topic is about how Medicaid pays for services. There are a lot of different ways of doing this, and some of you are probably pretty familiar with the ways in which Medicaid pays for services in Michigan, but most states use a mix of payment models. I don't think there are any states that pay for services only in one way. There are, come on now, you can do it. Okay, so fee for service, we'll talk about each of these in turn for a little bit, but fee for service is what we refer to when we talk about reimbursement for services. Well, alternative payment models are becoming very attractive because of the things that they can incentivize in the service providers, that they can encourage people to improve quality and things like that. Somewhere in the middle is managed care. Michigan, of course, is a managed care state, and it is very prevalent. There are about 3/4 of the states, maybe more now, are in managed care. There are others that are just getting into it, like Oklahoma has just authorized conversion of their program to managed care. So the payment methods that are used vary in how they work and why people have proposed them, but the alternative payment methods are meant to pay for value rather than volume. That's the sort of the mantra that people are saying. We want to incentivize better quality services, not necessarily more services. There are alternative structures like accountable care organizations. In some states like Rhode Island, they call them accountable entities. And they are responsible for more aspects of the full range of care for individuals that are enrolled in them. And the financing is meant to incentivize both high quality care and cost savings. The federally qualified health centers are a special case. In most states, they are paid using what is called prospective payment system, which is a negotiated rate based on their total cost of operations, which they are paid, they bill Medicaid or a health plan, they bill per encounter, per visit. And that is a fixed rate. The problem with that is that a contact by a CHW in itself does not constitute an encounter. And so the FQHCs can't bill for an encounter that is just between a CHW and a client or patient. So looking at a little more depth, fee for service basically is a payer like the state or a managed care organization or health plan. They will reimburse it, on submission of a claim or a bill for individual units of service after the service is delivered. So it is literally reimbursement. And this, in the case of managed care, most managed care states do pay, the state itself will pay directly for some services. This is mainly long-term care. So many of them, even if they are a managed care state, the state will pay directly to nursing homes for long-term care services. The dilemma for most people just don't like it, but they feel like they're stuck with it. Fee for service gives an incentive to providers to provide as many billable units of service as they can get away with. And that is troublesome for a lot of reasons. So the state feels like they are stuck paying for a quantity of services rather than outcomes or quality. So that's one of the, and of course the providers don't like it because the billing can be very cumbersome. So nobody really likes it. We're stuck with it, at least to some extent in every state. Managed care get a premium or a what they call a capitation payment per member per month for each member, and the rates will vary depending on eligibility categories or what they might call risk categories. For example, the premium they receive for younger children, say ages 1 to 6, are relatively low because by and large, young children don't have that much in the way of healthcare needs. And so those premiums are going to be lower than for other categories of members. Depending on the contract, the managed care organization must pay for most of the services received by their members out of that revenue, out of those premiums. Now, they often turn around and pay, the managed care organizations pay the providers on a fee-for-service basis, but some of them are turning around and doing what we call subcapitation, or particularly with primary care. States like Massachusetts and California are beginning to establish subcapitation payments where the health plans will pay a primary care provider a certain amount per member per month for just the primary care services that they receive. So it's getting a little more complicated over time, but managed care is an important way by which most states shed a lot of the administrative burden of running Medicaid. And so it's interesting because the managed care organization has limits on how much they can spend on administration. It's typically like 15% of their revenue that they are allowed to spend on administration and executive compensation and profit and all of that. And so it is also true that around the country, many of these managed care organizations are at their own initiative paying for CHWs or employing them as an administrative expense because it benefits their business. Even though they have limits on these administrative expenses, they are finding it worthwhile to spend money on CHWs for the results that they achieve. And in Michigan, roughly 80% of Medicaid recipients get their services through one of your managed care organizations. And however, that only accounts for about 60% of Medicaid spending. Only about 60% of the spending goes through the managed care organizations. And we can discuss any questions you have about all of that at another point. Now, Michigan is also somewhat of a special case in that you're the only state that has this particular provision in the health plan contracts. They must offer CHW supports to their members at a ratio of 1 full-time equivalent of CHW per 5,000 members. And I think you're probably all aware that that ratio used to be a lot lower or higher, depending on how you define it. It's more like 20,000 members. And a lot of folks around the country were looking at this and say, wow, this is great. You've achieved something that other states have not done. And then we've started to look more closely at it and realized that these expenditures are treated as administrative. And so the state did not have to go to the federal government for any approval for doing this. and it's simply part of the contract requirements. And so the hitch seems to be, and they're all technically in compliance with it, but that the state really has not established any meaningful standards. Montse, did you have?
Yeah, I was gonna say there's a question in the chat. There's
Okay,
it's 5,000 of the number of patients in the MCO by Tammy.
I'm sorry, say again.
The
5,000,
question, yeah, it's
5,000 what?
5,000. It's 5,000 the number of patients in the MCO question mark by Tammy.
Yeah, the MCOs refer to them as members. And so if they have, let's say 100,000 members enrolled, then they must employ or pay for the equivalent of 20 community health workers to serve those members. Does that answer the question? In other words, they don't have to be they don't have to actually be receiving medical care in order to get the assistance of the CHW. But they are Medicaid recipients are assigned to, or in most states, I'm sure it's true in Michigan, that they can choose which health plan they want to be enrolled in. They become members of that plan. So that's how they determine it. Okay. So the dilemma with this has been that the state has really kind of let the plans decide for themselves who they want to hire and what services they offer. And according to anecdotal stories that I've heard, some of them are not hiring people who would truly be considered community health workers. And that is unfortunate. So as a result of that kind of variability, the quality of the services that is being provided by CHWs will vary widely. And I think it's important for the future of CHWs in any state that we really strongly encourage or do what we need to do to make sure that CHWs who are paid under Medicaid are providing a range of things that CHWs are capable uniquely of doing. And is this provision encouraging the health plans to employ the CHWs in doing the kinds of things that CHWs uniquely can do? I leave that as a question for you all to discuss internally. But this is kind of a unique situation compared to other states, and I would not blame you if you were wanting this provision to be more meaningful to the workforce. Alternative payment models, there's a whole range of options here. And again, as I said, alternative payment models are meant to create incentives to provide greater quality, to improve access, to enhance health equity, and not simply pay for volumes of services. And so they often refer to this as value-based payment, where the contract with the provider says, in order to get paid, you have to reach certain standards of quality or a certain level of outcomes. And so these can be in the form of incentives or outright requirements. There are many different models. One of the easiest for a state to get into is to pay fee for service in general, but then for providers who meet certain quality goals, they can get bonuses, which may create incentives for them to do a better job. And that's the whole idea behind value-based payment, is to encourage people to do a better job. There's some certain programs, some states that have bundle payments, and they might, a typical example would be a joint replacement, a hip replacement or a knee replacement, where there is a package price for that. and a provider takes responsibility for it. They get paid that package price, and they're responsible for everything from surgery through rehabilitation for that patient, for that episode of care, for that joint replacement. And then there is the sharing of financial risk. And what that means is you get paid a certain amount for providing care to this population. And if you are very efficient and effective and you get good results at a lower cost, then you get to keep the surplus or the profit off the top. But if you don't do well and it costs you more than estimated for it, then you have to eat that loss. That's called downside risk. And so this is the way this is set up, and the negotiations for this are very complex. But the providers are basically trying to set a payment rate and conditions for payment that give them the best chance of making a profit. Okay. And they give them the greatest chance of avoiding a loss on that covered population. So it is again, it's an incentive to focus on quality and efficiency in the delivery of care, certainly. And then the most fundamental or basic form of this kind of risk sharing is capitation, which means that the provider gets paid in advance for each member that they are providing care for. And they've got to provide all the necessary care out of that revenue. And that is the ultimate in terms of turning all of the incentives over to that provider. So this is just really, I know this can make, and I know it makes my head spin after a while. So this is very complicated, and maybe if you want to have a more in-depth discussion of these kinds of questions, we can schedule something separate. But it is true that this is where people are trying to go. I will say that most states are are trying to do this, but having limited success or making limited progress. It's going to be slow going for a period of time. I have heard, however, that the managed care organizations in Michigan are starting to use alternative payment measures with providers, mainly in primary care. And that is the primary care setting is where a lot of employment opportunities exist for CHWs. So this is important, because if those providers have flexibility with the revenue that they receive, that gives them more opportunity and flexibility to employ CHWs to help to achieve the results that they're contracted for. Okay, that was a lot. So would like to give you again a block of time to kind of process all of that and see what sort of ideas or questions this comes up. It says groups of 2 or 3, but this is a fairly big group, so we're going to have larger groups for this. You'll have again about 10 minutes, but to discuss, and you can raise questions too, of course, but what's the most significant thing you've learned so far about how Medicaid pays for services?
There's actually a question right now in the chat. Carla,
Okay,
from
yes,
Jennifer.
please, go ahead. Yeah.
Yep. She said, is the per member per month considered a value-based payment model in your eyes?
Yeah, it is. I mean, what it means is this is how much the state thinks it should be paying for care for those individuals. And there will be quality standards for providing that care, but we're not going to examine in detail what services were actually provided. We want you to produce these quality results for this much per member or per patient. So that is that is considered to be a value-based payment model. Yes, as well. It is one option among many in terms of value-based payments. Okay. All right, with that, if
Looks like everyone is back now. Carl, you want to go ahead and share your screen?
yeah, great, thank you. Okay. There we are. Thank you all for participating in those small group discussions. And as we did the last time, if you could please enter comments in the chat, observations from your group, at least one statement about something you've learned so far. We will appreciate that. And we will move on. Okay, so let's put all this in context now a little bit, that we are all aware Medicaid is a big program. Just how big? In fiscal 21, the total national spending on Medicaid was $762 billion. That is a big number, and about a third of that was from the states itself. The rest, of course, from the federal government. And it is either the biggest or the second biggest item in most state budgets, right behind K-12 education. And the important point, however, is that the state has limited control over this. Once they've set the eligibility standards, they must enroll anybody who meets those eligibility standards. And that's one of the reasons why there has been some movement among some states to try to get approval to make Medicaid a block grant, which would place a cap on how much they could spend. And of course, that raises all kinds of political and ethical dilemmas. What happens if your state hits that cap and runs out of money, basically? Do you stop paying for people's health care? So that is, it is a big item. In Michigan, this was for the same period, about 16.5 billion. Again, a large figure. 60% of that spending, as I said before, going through managed care. So these are large numbers, and Michigan has about 2 million total recipients. I mentioned earlier, your match rate is about 65%, which is kind of in the middle of the pack. If you remember, I said it ranges for the wealthiest states about 50% up to about 84% for the very poorest states.
Hey, Carl, sorry to interrupt. There's a question from Julie.
Sure.
They're asking, are the programs in Michigan that provide care for specific groups of people for children with serious illness and breast and cervical cancer care only in Michigan, or are these federal programs that are in other states?
I'm pretty sure these are choices by the individual state, and I'm sure there are other people on the call who know more about those specific programs. I don't really know about them, but this is not universally the case. So this is a choice that Michigan has made. Does anybody on the call have, you want to unmute yourself if you know more about the specific circumstances of the programs that Julie's asking about?
I know less about those, but I think they are federal funds that come to the state.
Well, sure, but
Yeah.
it is something the state has opted to do. It's not something.
Right, exactly.
Not,
They've
yeah,
opted
yeah,
to do
it's
it.
it's
Right,
not,
right.
yeah, it's not something that all states are required to do. Yeah. Anybody else have more info on those? Yeah,
So
that's, I'm sorry, go ahead.
So these are programs the state has opted to use their Medicaid funds for, rather
Yes.
than ones that the federal government requires them to provide for
Yes.
accessing Medicaid. Okay.
Right. And I'll come back in a second to what services the federal government does require, because all states do some things that are optional above and beyond the mandatory services. But that's an excellent question, and it is important for everybody to be knowledgeable about what Michigan does that is above and beyond the federal requirements. Great point. So this is a quick breakdown, and for some people this is a little bit of a revelation, but that adults and children make up the vast majority of Medicaid recipients in any state, and most states look very similar to the Michigan profile. But the elderly and disabled use up a majority of the funds. And I think we can all understand why this is so. Of course, their needs are more complex. They have more medical needs. And so it's important to recognize kind of the equity dimension of this, that we're really trying to, this program is trying to level up, if you will, the access to care for elderly and disabled first. And it is simply true that the costs for adults and children on average are somewhat less than they are for them. I also have an example here of a more detailed breakdown, and I have not seen this specific breakdown for any other state, but for Rhode Island, this is for a different year. But the point is that they broke down elders and adults with disabilities, children and families under conventional Medicaid came out to 22% of the spending, but they also broke out their expansion, and the fact that the expansion added a lot of people in terms of enrollment, added 76,000 people, or 25% of their total current enrollment in people, but it only added 18%, or it only amounted to 18% of their actual spending. This is one of the measures that states use in advocating for expansion of those few states that have not expanded Medicaid. And it gives you a little more detailed picture here that the both for the elderly and adults with disabilities, that their expenditures are proportionally about 3 times the percentage of the population that's being covered. So, as you might imagine, and this is sort of an outgrowth of what the previous slide showed us, there are some states that are really particularly focused on high cost or high utilizer populations. And most states have some kind of focus on this. And if you all have specific examples from Michigan about how the state may be addressing this, that would be great. But New Mexico is the only state that has singled out the high utilizer population as a focus for a care coordination program involving CHWs. And this is a program funded through their managed care organizations that focuses care coordination services on those who use the most healthcare services. And this is very tempting for the state to do. Again, I use Rhode Island. I have not been able to find this similar statistics from other states, but they define high utilizers, high cost individuals, as costing $15,000 per person per year or more. And that amounts to, as you can see from this graph, is 9% of their enrollees are considered high cost. But look at this, they account for 73% of their Medicaid spending. And so think about that. If you were a state administrator one of the things you'd be saying is, whoa, we gotta get a handle on these high cost enrollees and how we can help to control the cost of their care. Well, yeah, you can certainly understand that. And at the same time, if you put all your eggs in that basket in terms of emphasis on quality and cost control and so forth, what is that doing for the other 91% of participants? Where is the equity? Where is the fairness in putting all your efforts into this very small group of enrollees? There's no simple answer to that question, but I invite you to be part of that inquiry. How do you balance the effort? Because it is clear that there are things that CHWs can do to help, and there's plenty of evidence in the research that community health workers can help to reduce the cost of these high utilizers, high cost enrollees. And the good news about it is that they reduce costs by providing better care. And that is really important because ethically, we don't want to get into questions about reducing benefits or denying, closing off eligibility as a way of controlling costs. Ethically, the best way to control costs is to provide better care. And so there are definitely things we know that CHWs can do with these high cost enrollees that will help to improve this cost picture. But I think the bigger question is, where should the roles of CHWs be in helping other Medicaid recipients in terms of access and quality of care and that sort of thing? So there's some very important questions embedded in all of this. I just wanted you to be aware that this imbalance does exist, that a small number of Medicaid enrollees cost the program a lot of money.
And Carol, we found during the pandemic, a lot of non-Medicaid enrollees, even privately insured, needed resources that they'd never needed before. And so I think there's a role for CHWs even in our private insured and of course the uninsured.
Sure. And that's another interesting conversation, because one of the things that that is sort of definitional to the CHW profession is that they achieve success through their ability to relate to the population they serve based on shared experience or lived experience in combination in comparison to the population they're serving in common with. And the question then becomes, if we're talking about people with perhaps higher incomes, what is the basis for the lived experience in common that creates that rapport? Not saying it's not possible, but it does underline the fact that the origins of CHWs are working with low income populations, with people of color, and that it's sort of uncharted territory when we talk about who is a CHW and what is their role in dealing with people at higher incomes. There's no question that people need assistance, but are we really talking about something more like a patient navigator? So that's a great question, and I think worthy of further debate. Yeah.
Right. And just one other comment is, when you do provide universal access to all people, it creates an equitable approach. But your services are based on what their needs are. And
right.
So the intensity of service can vary based on need, but it could be seen as an equity approach when everybody has access.
Yeah, sure. No, I think these are really valuable questions for you all to take up amongst yourselves, for sure. They are challenging questions. So but I'd like to turn now to why most states don't really have Medicaid coverage for CHW services, in spite of the opportunities that we see. We're going to come back to the opportunities again in a minute.
Hey, Carl, sorry.
Yes.
Oh, there's one more question.
Good.
Eric asked, what are the individual correlations for high utilization individuals? Is it chronic conditions, specific episodes, geographic region, rural, urban, exurb, suburb? Question mark.
Yeah, I'm not really following that. Let me pull up the is this in the chat?
Yes.
Okay. Okay, individual correlates. Oh, no, it's just spending. Oh, you mean in terms of what I couldn't really answer that question directly. But high utilization individuals are determined by the dollar volume of services that they require. It tends to be chronic conditions. It tend to be multiple chronic conditions. It tends to be comorbidities with behavioral health issues, but certainly not so much geographic correlates. It's much more clinical indicators. So, but I think it is the pattern tends to be, yes, the high cost individuals tend to be people with multiple chronic conditions and or behavioral health involvement. The rest of the stuff is not as strongly associated. So thank you for that question. So in this context, why in most states CHW services are not covered by Medicaid? First of all, back to the origin story of Medicaid, it is medical assistance. It is intended to pay for medical care. CHWs do not provide clinical care. And so with many states, it's kind of a stretch to think about CHW activity as being a medical care. I will be coming to a table here in a minute, which I teased you with a few minutes ago, that the services that CHWs provide are not included in the federally mandated benefits. So whatever states do with CHWs are optional. They are optional choices by that state to offer those benefits. And an increasing number of states are willing to do it, but it's not because they're mandated by the federal government. Further, CHWs are not defined as providers in the Social Security Act. And so if the states want to consider CHWs to be providers, they need to define them as such in the state Medicaid plan. There are a number of states that have implemented Medicaid payment for doulas and peer support services, which share a lot of commonalities with CHW, certainly in terms of core competencies. And it's my understanding that peer support specialists have been paid under Medicaid for quite a number of years, and that there is movement toward a payment for doulas. This seems to be happening in a lot of states. And I would just say briefly that it may be easier for these two occupations to achieve Medicaid payment because of the nature of their qualifications. I talked about lived experience as a qualification. This is also true, certainly in the case of peer support specialists, but the lived experience that's most important for peer supporters and for doulas has to do with a medical condition or issue. The lived experience for the community health worker has primarily to do with issues such as poverty and racism. And it is a lot easier for the healthcare establishment and for state officials to identify with experience with a health issue as a qualification. Okay, it's a lot easier for them to envision that as a qualification for these occupations. So it in some cases they have gotten a foot in the door, and community health workers have followed their lead, but it is still more challenging for CHWs. Let's put it that way, because of that distinction. Now, I mentioned I was going to show you a table. We're not going to spend time on this because it's pretty complicated. But these are, of course, almost entirely clinical services that we're talking about. These are the mandatory benefits, the original Medicaid, and then in the ACA, there are other services that need to be required. But the states, by and large, have chosen to offer at least some optional Medicaid benefits, and the closest that we get to things that CHWs do has to do with case management. And states have become very creative in terms of what they are offering or what they're using as the basis for justifying CHW services. But this gives you an idea of what we're trying to sort of shoehorn community health workers into a list of services that looks like this. Okay, and you will get a copy of these slides, of course, and you can study these in greater depth if you like. Now, all that being said, with all of those challenges, it is true that quite a number of states either have implemented CHW benefits for Medicaid recipients or are looking into how to do it and why are they interested. So none of this will be a real surprise, but what's important is the good news about these things, that Medicaid at the state and federal level is under pressure to improve the quality of care, to improve outcomes, to control costs. That's no big surprise. There is also a very welcome emphasis in recent years, an increased emphasis on health equity and social determinants. And as I said, the good news about both of these things is that we know these are things where CHWs can have an impact, that CHWs can help to improve care and control costs and improve the responsiveness of the system in terms of health equity and social determinants. So this is all good news. And I think the pandemic has helped focus a lot of people's attention on the fact that CHWs can do all of this stuff because they have realized that the populations that have been most affected by the pandemic, both clinically and socioeconomically, are populations that CHWs are adept at working with and achieving results with. And so they're saying, well, where have you been all my life, community health workers? Well, yeah, you've been around for a while. So it's nice to be appreciated. There is, however, a more basic kind of seismic shift in the world of healthcare, and this applies to all healthcare, not just Medicaid. And that is the fact that we're in the middle of a transition from a transactional model of care to relationship based. And what do I mean by that? By transactional, conventional Medicare, you experience a need for some kind of healthcare service. You seek out a healthcare provider. You receive a service. You pay for it or somebody else pays for it, and you walk away. It is a transaction. Okay. It's like buying an item in the grocery store. You get the item, you pay for it, and you walk away. Okay. And I have likened that in the past to kind of a vending machine. You need some help in a health related issue. You walk up to the vending machine, you put it in your card. Can't get away with putting in coins very often anymore. But you put in your card, you get the service, and you walk away. And I'm sorry, I couldn't resist the irony of using a bacon vending machine for that metaphor. But what we're moving to, however, through a variety of efforts in health reform have to do with we call relationship-based care or patient-centered care or family-centered care. Where we're looking at the entire environment surrounding that individual, where everybody who is assisting that family has some kind of relationship with them. They're getting to know them, getting to know their broader set of needs, and not just the immediate symptoms that are presenting when they show up at a provider's door. Okay, so this is where we see things like the patient-centered medical home and the accountable care organization and so on. And we often think about this in terms of trust and communication. And the good news again about community health workers is that they are the experts in establishing trust and communication with these folks. If you are a clinical provider, let's say a physician, there are immediate challenges in having a relationship with them because of perceived power differential with a low-income patient, with the patient's potential mistrust of institutions, and that you have limited time with them. You simply don't have the time to develop that relationship. And so in one of these settings, like a medical home or an accountable care organization, the CHWs can be the relationship specialists in that team or in that organization, or as a support to that organization, where the CHW may work for a community-based organization that is in partnership with a medical practice, let's say, that sort of thing. And this can be a tremendous boost. One of the fundamentals that we think about, I've talked to a lot of audiences of Medicaid providers, and I have said to them, how often have you seen a notation in a patient's chart that reads something like lost to follow-up? That is just a sad reality of working with a Medicaid patient population. Well, guess what? If you're a medical home or an accountable care organization, that's not okay. You can't lose people. You're not allowed to lose people. And so how are you going to maintain that relationship under those conditions? The answer, again, is community health workers. So I'm going to move on from that, but I think that is a really important mantra for us to keep in mind as we're talking about the pressures that are on the healthcare system today. So if we want to take a step back and what would it take for MDHHS to pay for a true range of activities or services from CHWs under Medicaid? There's some basic steps. First, you have to decide what services that CHWs or activities that CHWs can perform that would be most important to cover from Medicaid's perspective. And it could be something like prenatal or perinatal coaching to improve birth outcomes, something like that. Or it could be patient engagement in primary care, or it could be reducing preventable emergency room episodes, things like that. What are the services that are most important to Medicaid that you provide? Decide on how you can pay for that in a way that makes the most sense. Then estimate what it's going to cost, what the budget requirements are going to be, and hopefully what the potential cost savings will be from doing that. And then proceed through a process of state and federal approvals. The most common vehicles for that are a Medicaid state plan amendment, or what we call an 1115, section 1115 waiver. Okay, so those are the basics of what would need to happen. And we want to make sure that community health workers in Michigan and their advocates are at the table in each of the stages of that process. So here's where we come to the real payoff. If you've been multitasking through the rest of this webinar, now's the time to pay attention. So there are some key aspects of the choices that the state would make in designing this payment program that can have, and there may be others, I'm certain that there are others, but these are some of the key aspects of those choices the state's going to have to make that can have a profound impact on the work of CHWs. One is, of course, what services will be covered. The states that have done this so far have generally covered services in general buckets like health education, health promotion and coaching, and care coordination or navigation. So generally in those three buckets. And you can get pretty creative within those three buckets. And we have learned that CMS is quite willing to go along with what a state wants to do in those three buckets. The next one is, are there going to be limits on how many units of service, how much time a CHW can spend with a client or community member or patient per day, per month, per year, whatever. There are some states who have felt it necessary to impose limits in their payment policies of this nature. They may be afraid of runaway billing of some kind, whatever. But I note with great interest that Rhode Island, which is one of the most recent state amendments to be approved, they do not have a limit like this. It is true that the states so far are defining their benefits in terms of billable fee-for-service units. And they are, and there are reasons for that. A lot of states would like to go immediately to value-based payment, but they don't have enough data to set rates for a value-based payment. So they are choosing this unit of service system, and then they are imposing limits on how many of those. So for example, in some cases, they may say you can provide services for no more than X units, meaning like 2 hours a day. And one of the responses is, well, we teach diabetes classes that are 3 hours long. Does that mean we have to cut them down to 2 hours in order to be able to bill for them? That kind of question. And you do have to think through, how long is a community health worker going to be engaged with that community member or patient or client? Is it going to be 6 months, a year, open-ended, whatever it is? So that's one important consideration that can have a profound effect on how CHWs operate, and so they need to be part of this dialogue. What is the hourly rate of pay? I think we're all aware that nobody who is being paid out of Medicaid now as a provider, nobody feels that the rates are high enough. That's almost a given. You're going to have to start out with something that's not entirely satisfactory. But it is important to remember that the billing rate needs to be more than just the direct salary and benefits of the worker for those billable units of service. That there need to be some indirect costs in terms of supervision and infrastructure, and importantly, non-billable time. The nature of CHW work is that they will spend inevitably a certain amount of non-billable time in developing and maintaining relationships. And there's no way that you can, there may be some creative ways you can bill for some of that, if you call it assessment or something like that. But there's going to be a certain amount of non-billable time that has to be covered for that employer. In what settings will Medicaid pay for CHW services? Community health workers work in a lot of different settings. Some of them work in a clinic or hospital setting part of the time, or even all of the time. Some of them do a lot of home visits. Some spend most of their time in the community. I would suggest you consider, if at all possible, that any setting is okay. because in some states they're saying that for different reasons, there are interest groups saying CHW should only be billable for services delivered in a clinic setting. And then in other states, they will say just the opposite, that CHWs cannot bill for time spent in a clinic setting because it may compete with the scope of practice of somebody else. So that needs to be a robust discussion, but I would certainly encourage you to work toward as broad a definition of setting as you can. I need to hurry to finish up here. Who may refer for order or recommend community health worker services? The way Medicaid regs work, a clinical or a licensed or authorized clinician must either refer or recommend or order the services of a CHW in order for it to be billable. And so each state makes its own definition of who may authorize it in that way. There's a subtle distinction. There are two basic regulatory authorities that the states can use for billing for Medicaid, billing Medicaid for CHW services. One is the other licensed professional regulation, and the other is the preventive services regulation. Both require that one of these qualified clinicians recommend the services. In the case of the other licensed professional, other licensed provider, that requires that licensed clinician actually supervise the CHW. So there are important decisions to be made about whether you want it to be required that they be supervised directly by them or can be supervised by somebody else. And by the way, orders for CHW services, it has been upheld in multiple states that orders for CHW services can be in the form of standing orders, where a licensed person can say, under these conditions, this CHW service is authorized on a standing basis. And so it is, that is a great opportunity for making it as flexible as possible. Right. So, and then the last one, which is a really big one, because a large percentage of CHWs are employed in community-based organizations rather than healthcare organizations, that we have some efforts and states are making concerted efforts to find ways to deal the community-based organizations in, so to speak, to make sure that they are not left out, that they do not find, for example, Medicaid billing to be so burdensome that they can't participate, that there are creative ways through partnerships or contracts with healthcare providers or other creative arrangements. Like you have of course, Michigan was one of the first states to implement the Pathways Community Hub model, which is one way of getting at that. And it has other benefits in terms of being multi-payer, but I noticed that the states recently authorizing Medicaid payment for CHWs have gone to great lengths to get into dialogue with community-based organizations about how they can participate, because I think this is really important. I think in your MICHWA employer surveys, the numbers of the percentage of CHWs employed in CBOs has been as high as 40%. And we certainly don't want to close those organizations out when these policies are developed. So lastly, in these slides, here's this slide with some links to resources that I encourage you to follow for self-study. And some of the national sources have a lot of great data and suggestions about how you can do what you want to do. So I'm going to go back to our poll. Montse, if we can run this again very quickly, and if you can be, while you are responding to to this poll. If you have other questions or comments you would like to put in the chat while others are responding to the poll, could you please do that? Well, we sort of ran out of time. We don't have a whole lot of time for discussion, but if there's enough demand, maybe we can arrange another kind of follow-up session at a future date. So I see we've got about 2/3 of you in the poll. Okay, mostly I think we can go ahead and end that. So I'm glad to see that a few of you are now at the lowest level of confidence. There has been some increase. I think we have a way to go in terms of getting you to be more or at the very most confidence level. So that's great. So what I would like to allow some time for we have a few minutes left for questions, comments, but I do want to acknowledge first that this webinar was developed with the support of the CHW Association of Rhode Island and the Rhode Island Department of Health, and we appreciate their granting permission to offer it to other states. So, Monse, do we have any additional comments in the or questions in the chat?
No questions. Everyone's just thanking you for your time and the representation. Thank you, Carl.
Great. Well, thank you all for your participation in this, and I will be very interested if I'm going to drop my email in the chat here if any of you want to, oops, where'd the chat go? There it is. Okay. If any of you want to reach out to me directly, I'd be glad to. Oops. Sorry, that is incorrect. Okay, I hope that's clear. Okay. Well, again, thank you for the opportunity to get together and talk about this stuff. And I hope we can be of further assistance as you move forward, advancing CHWs with Medicaid in Michigan. And thank you, Monse, for your support in running the webinar. Anybody that any last minute